Welcome. Today we're going to speak about tobacco and alcohol, two critical risk factors for health. By the time you finish this session, you should be able to speak comfortably about the importance of tobacco and alcohol to the burden of disease, the health, economic, and social consequences of tobacco consumption and excess alcohol use, and selected measures for addressing tobacco and alcohol use. Let's speak first about tobacco. Tobacco is an especially important risk factor for cardiovascular disease, cancer, and diabetes, and therefore it bears specific discussion of its own. As you can see in this graphic, tobacco consumption, smoking, was the second leading risk factor globally in low and middle income countries and in high income countries that related to deaths in 2013. In fact, when we look at the same for DALYs, we'll see that smoking is again an especially important risk factor. It's the second leading risk factor for DALYs globally. It's the fourth leading risk factor for DALYs in low and middle income countries, and the third leading risk factor for DALYs in high-income countries. It's estimated that about 5 million deaths annually are associated with the use of tobacco, and about half of those deaths are actually in low-income countries. It's also estimated that 1 in 5 males over 30 and 1 in 20 females over 30 who die worldwide actually die of tobacco-related deaths. Ultimately, 1/2 to 2/3 of those who smoke will die of causes related to tobacco consumption. In addition, half of all tobacco-related deaths occur among people who are 35 to 69 years of age. The most common tobacco-related deaths, as most of you will know, are from cardiovascular disease, diseases of the respiratory system such as emphysema, and from cancers. Tobacco use can also increase, and many of you don't know this, tobacco use can also increase the risk of getting tuberculosis or dying from it, as well as substantially increase the risk of becoming diabetic. Most tobacco is used through either smoking cigarettes or bidis, which are hand-rolled cigarettes used largely in South Asia. It's estimated that about 1.5 billion people worldwide smoke tobacco. And of countries that participated in a recent review by the World Health Organization on tobacco prevalence, Russia had the highest rate of smoking at about 39% of all adults. Indonesia was second at about 35%, and Nigeria, among those countries that participated in this survey, was the lowest at just below 4%. In all regions of the world, men smoke more than women do. This is most pronounced in the low-income countries, in which relatively small share of women smoke. And here we see, in fact, a graphic that looks at smoking prevalence by sex, with females in orange and males in blue, for World Bank regions, high-income countries, and globally for 2011. We see, as I mentioned, that consistently females smoke at lower rates than men do. We also see how that ranges from very low amounts to about 22 in Europe and Central Asia, and about the same in the high-income countries. We also see that among men, it varies from as low as 26% in Latin America and the Caribbean to as high as almost half of all men in East Asia and the Pacific. When we think about individual countries, the highest rate of smoking prevalence among males is actually 67. I'm going to repeat, 67%. 2/3 of all the men in Indonesia smoke, as Shaylin assents to, having lived there, and despite her deep affection for the country, she recognizes this is an extraordinary share of the adult male population which smokes, and a lot of youngsters smoke too. Russia had the second highest rate of prevalence at just over 60%. Of the countries surveyed, the lowest rates of smoking among women were less than half of 1% in Uruguay and about half of 1% in Egypt. Now, the extent to which people take up smoking varies not only by sex, but also by socioeconomic status and level of educational attainment, as I think almost everyone understands. The higher the socioeconomic status and the higher the level of educational attainment, the less likely one is to smoke. The lower the educational attainment and the lower the socioeconomic status, the more likely one is to smoke. Most people, as you also know, start as teens. But it's especially important if we're going to bend the curve and reduce the number of people who smoke, that we both prevent people from starting to smoke, but also try to ensure that some of the smokers who smoke today, in fact, as many as possible, stop smoking. This will not be easy. Tobacco is physically addictive, and once one starts to smoke, as you also know, it's not easy to stop. In some countries such as Canada, Poland, Thailand, the United Kingdom, and the United States, and Uruguay, the use of tobacco has been declining, often linked to some very successful policy efforts and regulation on behalf of these countries. However, the rates of smoking continue to grow in a number of settings, especially in low and middle income countries among men, and actually in almost all regions, the share of women who are smoking tobacco is actually going up. And I think, as you understand, what happens is when countries are relatively lower income, they don't smoke. The prevalence of smoking is not usually very high. As they become more middle income and as gender roles become more equal, the rates of smoking grow first for men and then for women. And then as countries become higher income, but couple their being higher income with measures to address tobacco consumption, the rates of tobacco consumption usually begin to fall, both among men and among women. What's quite clear, though, is unless steps are taken to stop the spread of tobacco use, we're likely to see continued growth in cardiovascular disease and cancers related to smoking. And many of these are avoidable, and the overwhelming share of these are actually going to occur in today's low and middle income countries. Studies on the cost of smoking have largely been done in high income countries, and there's not that much data on the cost of smoking in low and middle income countries. The costs of the studies that have been done have suggested that the cost to the economy of tobacco consumption varies from about 0.1% to just over 1% of gross domestic product. Now, it's estimated that 70 million people died of smoking-related causes between 1950 and 2000, and that if present trends continue in tobacco use, an additional 150 million people will die of smoking-related causes between 2000 and 2025. And of course, the health, individual, societal, and economic costs of this will be great. And this highlights again the need to get present smokers to quit, as well as to stop people from taking up tobacco consumption in the first place. Now, the Framework Convention on Tobacco, which the global community agreed to in 2003, outlines measures that countries have agreed to undertake to reduce both the demand for and the supply of tobacco. And the World Health Organization has elaborated on these measures by outlining a program called Empower, which specifies particular measures that can be taken to reduce tobacco use. This includes setting up an ability to monitor tobacco use and to promote prevention policies, offering help to quit tobacco use, enforcing bans on tobacco advertising, promotion, and sponsorship, raising taxes on tobacco, warning, like through warning labels about the dangers of tobacco use, and preventing people from tobacco use through measures such as smoke-free zones. Let's now speak about alcohol. as we begin, it's important to understand that the burden of disease study considers alcohol use disorders a cause or a kind of health condition on its own. However, the study also considers alcohol a risk factor for other conditions. To avoid confusion on this matter, I'm going to speak mostly of the cause referred to in the study as alcohol use disorders. Alcohol is a major public health problem. About 0.7%, just under 1% of the global burden of disease in DALYs is attributable to alcohol use disorders. About 1.5% of the burden of disease in DALYs in high-income countries and 0.6% in low-income countries is attributable to those disorders. Globally, this is similar to the burden of anxiety disorders and drug use disorders. In addition, as we can see in the next graphic, alcohol use disorders are the 10th leading attributable risk factor for deaths globally, the 9th leading attributable risk factor for deaths in low and middle income countries, and the 6th leading attributable risk factor for deaths in high income countries. When we look at the next graphic at DALYs, we'll see that alcohol is the 6th leading attributable risk factor for DALYs globally, the 8th for DALYs in low and middle income countries, and the 4th for DALYs in high income countries. When we think about DALYs, it's important to note that about 4% of the global burden of disease as estimated in 2009 was attributable to alcohol use disorders. That would have been the same amount as the burden related to tobacco and hypertension, and slightly more at the time than was attributable to depression. Now, high-risk drinking, as we see in the next graphic, has been defined as drinking 20 grams or more per day of pure alcohol for a woman and 40 grams a day for a man. This is equal to about 1/4 of a bottle of wine for a woman and about 1/2 a bottle of wine for a man. High-risk drinking may also be defined in ways that include the total amount that's consumed, the frequency with which it's consumed, and the extent to which one engages in what they call binge drinking, drinking a lot at once. High-risk drinking has a negative effect on people's health in a number of ways, as shown in the next graphic. It increases the risk of hypertension, liver damage, pancreatic damage, hormonal problems, and heart disease. Alcohol intoxication is associated with accidents, injuries, accidental deaths, and risky behaviors. Alcohol dependence has a variety of negative psychological and physical consequences and can also be associated, as many of you know, with fetal alcohol syndrome. The prevalence of high-risk drinking varies by region. It's been estimated that men in Europe and Central Asia have the highest rates of high-risk drinking. About 21% of the men between 45 and 59 years of ages. People in the Middle East and North Africa have the lowest rates, which are thought to be quite low. South Asia has a very low prevalence of high-risk drinking, and the prevalence rate of high-risk drinking, of course, also varies by age and by sex, with a lower rate of prevalence of high-risk drinking in people above 60 than in younger ages. In every region of the world except South Asia, men engage in high-risk drinking more than women do. There's relatively little evidence about the determinants and risk factors for high-risk drinking, especially in low-income settings. Studies done in high-income countries suggest, however, that lower socioeconomic status and lower educational attainment are risk factors for drinking to the level of intoxication. Now, alcohol use disorders, like tobacco consumption, have very high economic consequences. Most of the data on the costs and consequences come from high-income countries, but it's not so difficult to extrapolate to the lower and middle income countries. First, excessive alcohol use is associated, as you just saw, with a range of health problems for the drinker. It's also linked, as you also just saw, to violence and injuries caused by the drinker, such as when driving while intoxicated. When calculating the economic costs of excessive alcohol drinking, one therefore has to take account of the direct health costs for the user, as well as the consequences of the user's actions on others people whose injuries or bad health might be caused by the action of the person who engages in excessive alcohol consumption. The indirect costs of excessive alcohol drinking will include the productivity losses of the drinker and the productivity losses of people hurt by the drinker because of his or her excessive drinking. There have only been a small number of studies that looked at the costs of alcohol abuse, but as you can see in the next graphic, they've estimated that this could range as a share of gross domestic product from around 1% to as high as almost 6%. And a 2009 study that examined the economic costs attributable to alcohol in 4 high-income countries and 2 middle-income countries suggested that the cost ranged from around 1% to around 3% of GDP. Despite the high burden of disease and the high economic costs associated with excessive alcohol consumption, very few low and middle income countries have embarked on measures to address this in a coherent manner. And yet we know that there are a number of steps similar that those can be taken for tobacco that can in fact lead to reductions in excessive alcohol use. Just as is the case for tobacco, we know that taxing alcohol to raise its cost can lead to reductions in consumption. But one has to be a little bit careful about this, because if you tax tobacco, you might get smuggling. But if you actually tax alcohol use, you might wind up with illicit production of alcohol that can produce alcohol that's actually poisonous and can lead to deaths. There's also a number of studies, at least in high-income countries, that show that you can reduce alcohol consumption by reducing the number of hours during which alcohol is sold. And in a number of healthcare settings, especially in high-income countries, there's been some success in brief counseling sessions with people who suffer from excess alcohol consumption and trying to encourage them through these sessions to reduce their excessive consumption of alcohol. A recent study that was part of a broader major review of alcohol and health suggested that countries, particularly low and middle income countries that may lack the capacity to take on all of these measures to reduce alcohol consumption, should take what they call a stepwise approach that would begin with increasing taxes and then move through reducing availability and sales, both generally and to minors. That would then include checking on the sobriety of drivers and also later involve these short counseling sessions with people who engage in excessive alcohol consumption. As countries move to the next level of addressing alcohol abuse, they can, for example, also ban sales and drinking in public places, regulate discounts on alcohol, and do random breath testing. At the last level, countries could set high minimum prices for alcohol, ban all forms of product marketing, and restrict the design of packaging. And they could also provide mandatory treatment for drunk driving, as well as treatment options for alcoholism. Tobacco consumption is a major attributable risk factor for deaths and DALYs. Alcohol use disorders are an important cause and risk factor for deaths and DALYs as well. The significance of tobacco consumption and alcohol use disorders, however, varies by region and by sex. But in all cases, it's very important that countries, including low and middle income countries, take as quickly as they can the policy measures needed to address these issues, which often relate to raising prices through taxation, limiting sales, banning advertising for tobacco, and restricting sales to minors as well. Such steps, if implemented, effectively can yield high returns at low costs in the effort to reduce the burden of non-communicable diseases. In the next session, we're going to talk about mental health.